Right. I am the host. Yes, I am the host. Okay, Bailey, can you hear me?
Yes, I can hear you.
Okay, cool. We're going to do the quiz first, then we will resume after the quiz. So you won't hear anything for a little bit. It's not that I've forgotten you're there, it's that we're doing the quiz.
Okay, sounds good. Thank you.
Right. I hear someone coming up the stairs. Might be security for all I know. Okay. Stop. Please no. She gets one anyway. There's a question on the other side. Please don't forget to do it, like some of you in the past have done. It's one of those used for that. Okay, I just wasn't sure if it was. Right. Which one of you can tell me one difference? Let's just do this. Who can tell me a similarity between ulcerative colitis and Crohn's disease?
They both cause inflammation of the GI tract, but one's the cross. No,
Well, no,
the
I said similarities, so you can stop right there. We'll get to differences here. Very good. They're both in that group of diseases called inflammatory bowel diseases. Now, let's look at differences. Who can give me one difference between Crohn's disease and ulcerative colitis? Go ahead, Dusty.
ulcerative colitis affects primarily just the colon, where Crohn's disease affects both the small and large.
It can go anywhere from the mouth to the anus. How about the levels of the gastric layers? How do they differ and how they affect the gastric layers? Or is there a difference between the way they affect the gastric layers? How's the cobblestone look? Pseudopolyps. That's what you see in a colonoscopy. So if you take a biopsy of an ulcerative colitis affected colon, which layers of which mucosal layer is affected? Which tunic? Sorry? Bailey, you can answer too. Elizabeth, you're on the right track. The cobblestoning. Why does Crohn's do the cobblestoning? It affects the entire thickness of each tunic. So you have four tunics of the GI tract. Everywhere in the GI tract, you have the four tunics. Innermost layer is the mucosal layer. Below that is the submucosal layer. Below that is the muscularis layer, two layers of muscle, except in the stomach, you have three. Outer layer is either the serosa or adventitia, depending if the organ is retroperitoneal or intraperitoneal. Crohn's disease will affect all the layers. That's why you can get fistulas and perforations in Crohn's disease. Ulcerative colitis just affects the mucosal layer. Just affects the mucosal layer. All right, so we talked about aminosalicylates. These are used predominantly. These are used predominantly for ulcerative colitis. Their effectiveness when it comes to Crohn's disease is really not demonstrated. They're very good for maintenance. Maintenance. You can use them for induction and maintenance of remission, but if you use them for induction, you will need to pair them with corticosteroids typically. Typically extremely well tolerated. And the drugs are listed here. The one used the most is mesalamine. And you have sulfasalazine, balasalazine, olasalazine. Olsalazine. Very well tolerated. The most commonly reported side effects would be GI disturbances, things like nausea, vomiting, headache, and abdominal pain. There are reports of pancreatitis and hepatotoxicity, but those are not common. So on the average, these are pretty well tolerated. They come in an oral and a rectal form with mesalamine. The rectal form is called Rawasa, and there's a suppository called Canasa. Steroids are used to drive the flares into remission. You don't use these for long-term treatment. These come as oral preparations, of course. They also come for ulcerative colitis, rectal. Corticosteroids, it's a rectal foam. The one that's used the most is budesonide, which I don't think is on there. So budesonide that's used for asthma also comes in a rectal foam. Why don't you want to use steroids long term? Cushing syndrome, right? Exactly. Exactly. So I could read you the litany of side effects, but you can probably recite them as well as I can. All right, immunomodulators. We talked about these, the thiopurines. So there's 6-mercaptopurine. That's an active metabolite of azathioprine. Azathioprine is converted into 6-mercaptopurine. They interfere with purine biosynthesis, so they interfere with the expansion of immune cells. These are steroid-sparing agents. You don't need to be on steroids, and they're used typically to maintain remission. These will take about 3 to 6 months to start working. These won't start working right away. In addition, there's methotrexate. This will induce and maintain remission of both Crohn's disease and ulcerative colitis. The thiopurines, 6-mercaptopurine, azathioprine, they can cause myelosuppression, bone marrow suppression, and they can cause hepatotoxicity. So the 2 tests you're going to do, if people are on those, is liver function test and a complete blood count. In order to metabolize these drugs, there is an enzyme that's called thiopurine methyltransferase. Some people have a gene that encodes that enzyme that encodes a defective enzyme. If you have a defective thiopurine methyltransferase, your thiopurine levels are going to be really high and you're at increased risk for myelosuppression. So before you put someone on thiopurines for long term, you should have them gene tested, or TPMT, thiopurine methyltransferase. Thiopurines can also increase the risk of infection. They can also cause nausea. Boy, this thing is a chalk magnet. So they cause some nausea, vomiting, diarrhea. They can also cause a rash. They can cause pulmonary edema, pancreatitis. There's also an increased risk of non-melanoma skin cancers when you're on these drugs. Long-term thiopurine treatment has been associated with an increased risk of lymphoma. There are some papers that debate that, but it is pretty much thought among gastroenterologists that you do need to screen people for lymphoma while they're on these drugs. We've talked about methotrexate already, so I'm just going to leave that for you to review. All right? Do you guys remember methotrexate from when we talked about it? When we talked about drugs for rheumatoid arthritis? Yeah, so it's also used for things like UC, so on and so forth. Same thing with the TNF inhibitors. We talked about those already as well. Those are used both for ulcerative colitis and Crohn's disease. The drug adalimumab, otherwise known as Humira, is quite effective in Crohn's disease. Having said that, there aren't a lot of head-to-head comparisons between these drugs, but several reports say that people who could not get any response from infliximab had lots of remission and fistula closures when they were put on adalimumab. So adalimumab seems to be particularly effective. Certolizumab, Cimzia, doesn't seem to be as effective as adalimumab. That's just based on comparisons of responses. There are no head-to-head comparisons. So that's based on clinical observations. The hardcore head-to-head comparisons have not yet been done. These drugs can be used with thiopurines. They can be used with methotrexate. However, if you combine thiopurines with anti-TNF agents, you increase the risk of lymphoma. How are you going to screen people for lymphoma? How do you do that? You guys are making this way too complicated. CBC. Yeah, CBC. The machine will detect abnormal cells because it won't be able to categorize them. And antibiotics are effective for Crohn's disease and not for ulcerative colitis, because remember, Crohn's disease is due to an immune response against the bacteria in the gut. And the two drugs that are used are metronidazole and ciprofloxacin. Nicotine. Now, this is weird. So smoking increases your risk for Crohn's disease, but it seems to be protective when it comes to ulcerative colitis. So that has led some enterprising clinicians to propose nicotine patches for ulcerative colitis. Now, we talked about nicotine patches. We talked about some of the side effects of skin irritation, the tachycardia, and so on and so forth, insomnia, nervousness, and what have you. Seems to help active ulcerative colitis, but it's not a good maintenance treatment. And it does not help with Crohn's disease. In fact, it can worsen Crohn's disease. Most of the data is case reports and people sharing drinks over cocktails at conferences. We need more controlled trials. The only trials I've seen are open label and are small. All right. So if you want the patient to have fewer bowel movements, because typically with things like ulcerative colitis and Crohn's disease, Bowel movements can be a big issue. So antidiarrheals are sometimes used. Be careful with these. If you overuse them, you increase the risk of toxic megacolon, particularly in the case of ulcerative colitis. So loperamide combined with the diphenoxylate and atropine, that's called Lomotil. That particular drug will decrease the number of bowel movements, as will things that are antispasmodics that are typically used for irritable bowel syndrome. But use them with caution. Use them with caution. And that leads us now to a discussion of irritable bowel syndrome. There is one drug I did not talk about that I should talk about because it's now becoming one of the standard treatments, and that's a drug called vedolizumab. This is a drug that goes by the name Entyvio. So this drug is an antibody against a specific integrin that lymphocytes use to enter the bowel. And it's the alpha 4 beta 7 integrin that's a target of this antibody. So this antibody binds this integrin and it prevents lymphocyte entrance into the bowel. The drug is quite effective both for ulcerative colitis and Crohn's disease, and it's becoming one of the new standard treatments. It's also very well tolerated. Most of the side effects that are reported are pretty low percentage things. The drug is also not associated with an increased risk of malignancy. That's one of the big pluses of that particular drug. And there are some other types of drugs that are used. We talked about JAK inhibitors. Some of the JAK inhibitors are being used. And so is this other one we talked about, ustekinumab, the interleukin 12, interleukin 23 antagonist. There are also interleukin 23 antagonists that are being used as well. I think we talked about those. Risankizumab, I think we talked about that when we talked about psoriasis. That's also being used. It's not clear that you get better results than you do with the anti-TNF drugs. Okay, irritable bowel syndrome, unless there's any questions about drugs for those. All right. Irritable bowel syndrome is weird because nobody really knows what causes it. So it's more common in women. It's exacerbated by stress. Some people say, oh, it's caused by stress. That's not clear. It can affect as many as 20% of adults worldwide. It's chronic, it recurs. There are 3 types. There's a constipation predominant disease. there's a diarrhea predominant disease, and then there's a mixed pattern that's a little bit of both. One of the big issues with irritable bowel syndrome is the bowel spasms. And that spasming of the bowel can be incredibly painful. So the manifestations will vary. But when it comes to constipation, dietary modification is usually increased fiber intake and increased water. Usually works. And then laxatives. And that includes milk of magnesia. That's what mom is. Miralax, which is a polyethylene glycol polymer that sucks up a lot of water. Bisacodyl, that's the product Dulcolax. And then a drug called lactulose. Lactulose works really well. So if a patient takes lactulose, tell them to be ready. Because it's going to work. The diarrhea predominant disease, typically this is tipped off by particular foods. You tell the patient to avoid those foods. It will vary from patient to patient. The ones I have up here, caffeine, alcohol, maybe lactose, those are pretty standard, pretty common, but it might be spicy foods for some people. It might be avocados. It might be, who knows? And so you try to get the patient to identify what their particular food trigger is, and they avoid it. And then there are antidiarrheals that you can use to, if they have a flare-up. So loperamide is a drug that they can just have and take when they get a flare-up. Then there's the mixed pattern disease. And this one has a lot of spasm when you use antispasmodics. It's these two drugs that are used very commonly. Dicyclomine and iosamine. Antidepressants are used off-label. They're used really commonly, but the evidence base for them is pretty crummy. But they're used a lot, so whatever. All right, so other treatments for example, the irritable bowel syndrome characterized by constipation, there's a drug called lubiprostone. This is a prostaglandin derivative. It activates gastrointestinal chloride channels. By activating those channels, it stimulates intestinal fluid secretion. So this will give you increased water. That will decrease constipation quite nicely. Another is a drug called linaclotide. Linaclotide. There's now another drug that is related to linaclotide called plecanatide. Plecanatide, it works the same way as linaclotide. So these particular drugs, they activate guanylate cyclase C. And guanylate cyclase C receptors on the intestinal epithelium increase intracellular concentrations of cyclic GMP. That activates again, another chloride channel, and it increases luminal intestinal secretions. That accelerates intestinal transit. Then there's another drug that is a little bit newer. It's called tenapanor. The trade name of this drug is Ibsrela. Sounds like a little girl's name or something like that. This particular drug has kind of a novel mode of action. It inhibits the sodium hydrogen exchanger 3. This is the sodium hydrogen exchanger. Because it inhibits sodium absorption in the colon, the more water stays in the colon. And it increases intestinal transit time. All right, so how well are these drugs tolerated? Lubipristone tends to cause nausea and diarrhea about 8 to 7% of the time. So not very commonly. Other than that, it's pretty well tolerated. Do not combine this drug with methadone. Methadone will reduce the activity of lubiprostone. Linaclotide and plecanatide. These will cause typically diarrhea, although linaclotide will cause more diarrhea than plecanatide. You'll also get some gas with these drugs, abdominal pain, and your stomach will just feel full. Dehydration is a potential issue, so tell your patient to hydrate. Tenapanor, again, will cause usually diarrhea. Gas and abdominal distension have been reported, but only in about 3% of patients. And again, there's a potential for dehydration. So make sure your patient is drinking. Antidepressants have been used actually for quite a while for irritable bowel syndrome. Again, evidence base is lousy. Just don't go there. Don't go there. These were used a long time ago when there was nothing else. Now they're better drugs. So just no, don't go there. A Losartran or Lotranex is a serotonin HT4, 5-HT4 receptor agonist. Now, this drug was originally taken off the market. Then it was brought back after the data was reassessed. However, it is only to be used in women younger than 65 years old who have not had a stroke, have angina, or have had a heart attack. And that's used for the diarrheal type of irritable bowel syndrome. The two antispasmodics include dicyclomine, ioscamine. These drugs are largely anticholinergics. So you'll notice all the side effects are anticholinergic side effects. And these are those sorts of side effects that you expect from drugs like this. They do a good job with spasm. So if the patient has a lot of pain, in fact, I had a student one year who had irritable bowel syndrome. She would literally sit in class holding her stomach. Then she went to the doctor. The doctor put her on dicyclomine, and she had a new lease on life. Yeah, it was pretty cool. These are to be used on a PRN member, probate nata, as the need arises level, and then the types of anticholinergic effects that you get with those. All right, we're making some progress here. Things for vomiting. And here's where that handout I gave you comes in. Now, in the brainstem, in the medulla, there are some nuclei that are very close together. There's the CTZ, chemoreceptor trigger zone. You can see it's close to the fourth ventricle. It receives input from nerves from the stomach and small intestine. That has a direct line of neural connection to the vomit center right next door to it. And if these are activated, you get the vomiting reflex where peristalsis and the GI tract reverses itself. This is meant to prevent you from swallowing something that is bad for you. So there are chemoreceptors in the stomach. They detect poisons. They go to the CTZ, sends it to the vomit center, and boom, out it comes. Notice this also gets input from the semicircular canals. So you get really dizzy, and you might upchuck. Now, these particular neurons that you have in this brainstem set of neurons use certain neurotransmitters. They use dopamine and they use serotonin. So by blocking the effects of dopamine and serotonin, you can actually calm someone's stomach down. So first, there are the antihistamines, anticholinergics. These are used for nausea, vomiting due to motion sickness. So they include, of course, diphenhydramine, dimenhydrinate, that's Dramamine, hydroxyzine, mesclizine, which is available over the counter, and scopolamine, which you tend to do the patch behind the ear. These are anticholinergic, so they have anticholinergic effects. Keep that in mind. Phenothiazines. These are stronger antiemetics than the antihistamines, so they include these particular drugs that are antipsychotics in many cases. They're usually used at rather low dose. Again, they're inhibiting the dopamine receptors in the CTZ, the toxicity zone. So chlorpromazine, perfenazine, prochlorperazine, and promethazine, the drug known as Phenergan. Phenergan is used a lot in the ED. Someone comes in and they're very sick to their stomach. Phenergan is a good drug. That's promethazine. These can cause some extrapyramidal effects, so Parkinsonian types of effects. You use them for a long time, you can get decreased blood cell production by the marrow. They can sedate you and they can cause some cardiac arrhythmias. They can, in the elderly, cause excess sedation. So these are used for the mildly emetogenic forms of chemotherapy. So if you take a look at this sheet here, the emetogenic risk of these drugs are graded on a scale of 1 to 5. 5 is you're puking your guts out and everything else in between. 1 is you feel you have a sour stomach. So anything here essentially that's mild. So 1 or a 2 is nicely treated with a phenothiazine. The budesonide includes this drug, droperidol. That is used for postoperative nausea and vomiting. And it's an adjunct, again, it's not primary, but it's an adjunct for chemotherapy-induced nausea and vomiting. It also blocks dopamine stimulation of the CTZ. And this drug can cause sedation, pretty respectable sedation. Higher doses can cause cardiac arrhythmia. So the arrhythmias that you see there, that's dose dependent. This drug, however, plays well with other drugs, but if you combine it with other drugs that cause sedation, it's going to really put your patient under the table. Now, it could be you want them under the table because the sickness they're going to have is pretty bad. And if they're asleep, it's not that big a deal. Just keep in mind, if you sedate the daylights out of them, you can get respiratory suppression. So be careful. Steroids, so there's dexamethasone, methylprednisolone. That's for postoperative nausea and vomiting and for cancer-induced nausea and vomiting. Widely used, not used so much for chemotherapeutic-induced nausea and vomiting. We've talked about the side effects, and dexamethasone is a very powerful steroid. So it will cause lots of side effects. Not indicated for simple nausea and vomiting. You have other drugs for that. If your patient's diabetic, these drugs will mess with blood glucose. Then we get to Reglan. This drug is used a lot in hospitals. This is metoclopramide, or Reglan. So it is used for postoperative nausea and vomiting. That's what PONV is. It's used for chemotherapy-induced nausea and vomiting and for delayed chemotherapy-induced nausea and vomiting. And it's also used for nausea and vomiting induced by other drugs. That's why it gets used a lot in the hospital. So it blocks dopamine receptors in that chemical trigger zone. It increases gut motility, blocks serotonin receptors in the intestines. Because it's an antidopaminergic, you'll get some extrapyramidal effects. Restlessness, drowsiness, kind of dystonic reactions, fatigue, nausea, urinary retention, tachycardia, arrhythmia. You can give it with IV diphenhydramine to avoid these extrapyramidal effects. You will need to adjust the dose in people with bad kidneys. This drug gets used quite a bit. You don't want to use this drug, of course, in people with Parkinson's disease. Can you guess why? People with Parkinson's disease don't have enough Say it, dopamine. They don't have dopamine neurotransmission. If you block dopamine receptors, you're canceling out their medicine. So can't use this with people with Parkinson's. Then we have the selective serotonin antagonists. These are probably the most widely used antiemetics in healthcare. So these are going to block the 5-HT3 receptors. 5-HT3 receptors. And these drugs, as you can see, are used for all kinds of nausea and vomiting. Ondansetron, otherwise known as Zofran, the most widely used antiemetic in healthcare. Very cheap, very available, very well tolerated. And some of you who are seeing this have probably heard of it before. It's really widely used. Who's heard of it before? Say most of you. So this is blocking those serotonin receptors in the medulla that use a 5-HT3 receptor. It's also blocking those in the GI tract. It can cause some diarrhea. It can cause some fever. It can cause some constipation, some dizziness, drowsiness, arrhythmia, so on and so forth. There's also dolasetron, granisetron, and polonosetron. In head-to-head studies, they all seem to have similar efficacy. That's why ondansetron gets used because it's cheapest. It's also the oldest drug in this group. If you've got a drug that's a 4 or a 5, ondansetron by itself ain't going to cut it. But you can use it for a 3 or a 2 or something like that. Cannabinoids. Now, as you know, I'm a little bit hard on marijuana. Maybe I'm harder on it than I should be. But my dictum has always been, show me the data. And the data, frankly, has been pretty crummy, except when it comes to nausea and vomiting associated with cancer chemotherapy. The marijuana derivatives definitely do a good job. They can also increase appetite in someone with cancer who's lost their appetite. So out of these, the drug that's used the most is Marinol. That's dronabinol. There's also Nabilone, also known as Sesamet. They block prostaglandin and adrenergic activities. They can cause dependence. These are products, they are pills. They're not, someone is not toking up to get the effect. Someone wants to toke up in the hospital. The answer is no. Are you allowed to smoke in the hospital? No. Oh, it's my medicine. No, you'll take this medicine. So don't let someone pull that guilt trip bullcrap on you that I need my medicine in the hospital. No, don't fall for that. Furthermore, these drugs are a purified product. They don't have all the other things that you get in marijuana that could be interacting with this, and actually could be counteracting it. So they can cause dependence. They're reserved for patients who don't adequately get satisfactory results. Benzodiazepines, they're good for anticipatory nausea and vomiting. So let's say Brooke here and anesthesia, they just don't mix, but Brooke has to have, I don't know, someone stepped on her toe. She has to have her toe repaired. So she has to go under the knife. She's sitting there. Anesthesia. I hate anesthesia. I hate anesthesia. I'm going to puke. I'm going to puke. I'm going to puke. You ready? No, I'm going to puke. So they can give her benzodiazepines. That will not only calm her down, that will prevent her probably from puking. So it's for anticipatory nausea and vomiting. Can cause antegrade amnesia. They cause sedation and other things. We talked about benzos already. You got a patient as a fall risk, so increase the fall risk. These drugs here are the most powerful of the antiemetics. They are the neurokinin receptor antagonists. They all end in, as you can see, patent. Patent. So there's a prepitant. There are other drugs that are combined with polonositron. You have a variety of different possibilities, but because they inhibit neurokinins, if you have a 4 or a 5, these are the drugs you're going to give to prevent them from just throwing up everything in sight. So these drugs can cause some asthenia, weakness, needles and pins sort of feeling, dizziness, hiccups, fatigue. They're better tolerated than the nausea and vomiting, typically. Not recommended for long-term use, so use them when they get the chemo. Don't keep them on it. And aprepitant is the one that's usually used the most. And if someone is getting cisplatin, you have to give them aprepitant. Finally, there is Tygan, trimethylbenzamide, for postoperative and simple nausea and vomiting. Pretty well tolerated. Doesn't offer really any advantages over other agents, and it just prevents stimulation of the chemical trigger zone. Tends to cause us to be sleepy. Yeah. Does get used, but tends to be used if other things don't work. All right. Do you guys all have that handout I sent to you? We'll take a break and then we'll look at the handout. Okay?
I didn't hear the whole thing.
The one right here was the cricket phone, so I like couldn't really find it. And then what the very bottom.
Yeah. And it was like a door, and then there's like. Yeah, actually, I
Yeah. He was on. It's a hard time. And So where's your? Yeah.
You look tired, Brooke.
Yeah, we got back in just before 30. Yeah.
Who'd you play?
Very, and then our second game went to United Names, and then we had to stop at 3 different places for food. So, yeah.
How'd you guys play?
I mean, we didn't win either game, but we played pretty well. Obviously, the second game went 9 innings, so. First game we I think lost 6-0, but it was a 0-0 game going to the bottom of the fifth. So just kind of got out of hand in the I guess it was the 6th inning.
You had a bad inning.
Yeah.
Okay, well,
But they're a really good team and they're top 12 in the country. So
wow.
Yeah.
Are they better than I will?
Those two are always like they always split, but in my opinion, I think I was a better team.
Uh,
Marion has like a couple like really good players,
Uh-huh.
but Iowa's team is better in my opinion.
okay, so they have more talent,
Correct.
but okay.
Yeah.
So they're definitely the best two teams in the league.
And then after that, I'm gonna be honest, it's kind of all over the place. Like everyone's like records are very, very similar. So
Okay, folks, it's time to get back in the saddle. Please take the handout. We're going to look at drugs that are used largely to treat GERD, gastric esophageal reflux disease. All right, so if you go to D on your handout, those are the proton pump inhibitors. Remember, first of all, when it comes to GERD, lifestyle modifications like tobacco cessation, not lying down for at least 2 hours after eating or drinking, elevating the head of the bed. These should all be a component of GERD management. Likewise, weight loss can improve symptoms in patients who are overweight or have recently gained weight. And routinely avoiding foods associated with acid reflux. That would include things like caffeine, chocolate, alcohol, and spicy foods that can especially quell nocturnal symptoms. So the first go-to set of drugs include the proton pump inhibitors. Notice that these drugs all end with prazole. Prazole. So there's omeprazole, lansoprazole, rabeprazole, pantoprazole, esomeprazole, dexlansoprazole. These block the potassium hydrogen pump in parietal cells. And because it blocks that final pathway that culminates in acid production, it will block up to 99% of acid secretion. So dosing these drugs once a day will decrease GERD symptoms and will effectively heal esophagitis more effectively than any other drug group. So what are they used for? They're used for GERD. They're used for dyspepsias. They're used for Helicobacter pylori infections. They're used for stress ulcers, to prevent stress ulcers, and also for peptic ulcer disease. Some clinical considerations with the proton pump inhibitors. Number one, the patient needs to take them when they haven't eaten. Then they have to eat 30 minutes after having taken the drug to activate the proton pumps. So you take them on an empty stomach, and then you eat 30 minutes after having taken them. Secondly, if a patient has GERD, that acid is eroding the esophagus. They should not take these drugs on an as needed basis. They should take them regularly. Talk about side effects. Pretty well tolerated on the average. The side effects that are reported are usually all transient. So they include things like headache, nausea, abdominal pain, constipation, gassiness, diarrhea. Those are virtually all transient. Now, PPIs do increase the risk of Clostridioides difficile enterocolitis. The textbooks will say PPIs increase the risk of osteoporosis. Clinical trials have not confirmed this, but there is an association between long-term PPI use and an increased risk of fractures. So in osteoporosis, put a question mark by that one. There are reports that they increase B12 deficiencies. That's hard to confirm without further data. There's also reports that they can cause acute interstitial nephritis. Again, the clinical data on that's equivocal. Also, there are reports all over the web that long-term PPI use is associated with an increased risk of dementia. There is no data establishing that. There are no contraindications for these drugs except that many of them are prodrugs that need to be activated by cytochrome P450 2C19. If your patient has a cytochrome P450 2C19 that doesn't work, then the drug will not be activated. Questions about those drugs? Go up to C. Let's talk about the histamine 2 receptor antagonists. These also decrease stomach acid. So this includes the drugs listed there: famotidine, rhinantidine, cimetidine, and nizantidine. Notice they end in tidine. Tidine. These are not as effective as PPIs, but they might be better tolerated in some people. So these will block about 75% of stomach acid. They're used for the same thing. Now, cimetidine is a drug with lots of cytochrome P450 interactions. It inhibits cytochrome P450 2C19, 2D6, and 1A2. The other drugs are much less likely to inhibit cytochrome P450s. Rhinantidine has been removed from the market by the FDA because over-the-counter formulations of rhinantidine contain the carcinogen N-nitrosyl dimethylamine. So if your patient wants to take an over-the-counter histamine receptor antagonist, make sure it's not rhinantidine. No contraindications. These drugs are very well tolerated on the average. Some reports of headache, restlessness, dizziness, pretty low percentage stuff. Cimetidine will cause gynecomastia and impotence in males. I just think people should avoid cimetidine. They're better drugs. Now let's get up to the antacids and antacids plus alginic acid. There is a drug in that's called sucralfate. Sucralfate. Sucralfate is a aluminum hydroxide complex of sucrose. It acts locally and it protects ulcers from being exposed to acid and pepsin. So it heals peptic ulcers, and you can use it as a maintenance treatment to prevent ulcer recurrence. It doesn't tend to relieve ulcer pain. You have to take it multiple times a day, and it can reduce the absorption of other drugs if you take them with sucralfate. Looks like we might have lost somebody here. I think we lost Bailey. Well, okay, we'll keep going. On the average, the drug is well tolerated. It has a metallic taste because of the aluminum. It can cause constipation, and in patients, oh, you're back. In patients with renal problems, aluminum can build up and cause toxicity. So I would advise patients with renal problems don't use it. Next drug is F, the prostaglandin misoprostol. This drug reduces gastric acid secretion. It increases mucus and bicarbonate secretion. So it's a cytoprotective agent. The big contraindication for this drug is pregnancy. This drug will induce abortion. In fact, that's its other use. Oh, mercy, we lost Bailey again. This drug commonly causes diarrhea. That's pretty common. Also causes nausea, stomach cramps, and it can mess with a woman's menstrual cycle. She can have dysmenorrhea because of this drug. So are you going to give this drug to a woman of childbearing age? I wouldn't. Give it to a man? Sure. Sure. Give it to a woman who's postmenopausal? Sure. Give it like to one of you lot? No. No. All right. There's another drug that's not on here. It's kind of new. It's called vonoprazan. Vonoprazan. This is a very rapidly absorbed drug. It has a substantially longer duration of action than most proton pump inhibitors. Tends to be used for Helicobacter pylori infections. So it's usually combined with antibiotics to treat Helicobacter pylori infections. You don't use it in people with kidney dysfunction. You don't use it while breastfeeding. And don't use it in someone with a bad liver. This drug will cause some GI issues, can cause nausea, diarrhea, constipation. It can cause abdominal pain, and it increases the risk of urinary tract infections. Long-term use, there's hyperplasia of the gastric mucosa. And there are reports of Stevens-Johnson syndrome with this drug. Okay. The others are antacids. Those are all over the counter. The thing about antacids that you have to remember is that if you have a patient with some sort of compromised renal capabilities, the magnesium and aluminum hydroxides, they can build up and they can cause toxicities. Typically in people with normal kidney function, that's not an issue. So if someone has bad kidneys, usually calcium carbonate is a better drug. Those sorts of drugs require rather constant absorption. They can cause constipation and some acid-base disturbances. They're very rapidly active. That if you have an upset stomach and you pop some Tums, works pretty fast. It's not going to last very long. Alginic acid plus an antacid, that's this thing called Gaviscon. So Gaviscon forms a viscous solution that floats on the surface of gastric contents, and it acts as a barrier to acid reflux. It will cause nausea, constipation, and diarrhea. It requires frequent dosing, and it can prevent the absorption of other drugs as well. And those are the drugs for gastric disease. Turn to page 2, please. Let's talk a bit about drugs that are used for constipation. So one of the big causes of constipation is the lack of exercise. The other is insufficient fluid intake. The other is insufficient fiber intake. It's very clear from a variety of surveys that Americans don't eat enough dietary fiber. Also, certain foods contribute to constipation. They are dairy products, refined white flour products, alcoholic beverages, and, I'm sorry to say it, chocolate. So the first laxatives, as you can see, are the bulk forming laxatives. These are indigestible colloids. They absorb water. They form a bulky emollient gel. It distends the colon and it promotes peristalsis. They're pretty well tolerated, but they can cause increased bloating, increased gas, and abdominal fullness. They have a slow onset of action. You must maintain adequate hydration. And they can, if you don't have proper hydration, cause some obstruction in the GI tract. So these are products like psyllium. These are products like methylcellulose or carboxycellulose. Have you heard of a product called Benefiber? That's carboxycellulose. Polycarbophyll, Fibercon. Citracil, that's methylcellulose. All of these are these bulking laxatives. Second group are the osmotic laxatives. So that includes milk of magnesia, that's magnesium hydroxide, sorbitol, lactulose, magnesium citrate, magnesium biphosphate, polyethylene glycol, that's Miralax. These are non-absorbable compounds that draw water into the bowel. They create a watery stool. They're used as colonic cleansing agents before GI procedures. They work pretty quickly. You should have a nice bowel movement within 1 to 3 hours. You must maintain adequate hydration with proper use. They can cause gas, diarrhea, abdominal cramping, and some electrolyte disturbances, especially if you don't use them with enough water. D, or C rather, the stimulant laxatives. These stimulate the enteric nervous system. They irritate the bowel mucosa and increase motility. So this includes senna, which is an herb. So X-Lax. Yes, Ava, it is cold in here. Yeah. I have more insulation than you have, so I'm able to withstand it better. You don't have much insulation. I'm very well insulated. I worked hard on that, by the way. So X-Lax or Senecode or Benzocodal, these can cause some cramping, some nausea, diarrhea, fluid, electrolyte loss. They work pretty quickly. They might be required on a long-term basis, but they're safe for both acute and long-term use. They're also good to use with people taking chronic opioids. D, stool surfactant. These are softeners, and this is the compound Colace. Colace in trials versus placebo doesn't work. Colace gets recommended by lots of healthcare workers, and all the best data we have says it doesn't work. Now, in some people, it will work. So give that caveat if you recommend Colace. Colace is available in the store. I saw it on the shelves at Meijer when I went with my wife to Meijer. It's dirt cheap. It's a soap, basically. So it breaks up fecal material, allowing water to lubricate it, and it's also very well tolerated. But again, in a clinical trial versus placebo, it doesn't work. Don't use mineral oil. Some people use mineral oil. Don't use mineral oil. It impairs the absorption of fat-soluble vitamins. And don't use it. Then there are the Panoras, peripherally acting mu-opioid receptor antagonists. So we talked about methylnaltrexone. The other are naloxegol, alvimipam, and naldehyde. These can cause sweating, abdominal pain, gas. In severe cases, gastrointestinal perforation. These are to be used in people who have long-term opiate use prescribed. Use these short-term. Do not exceed 15 doses of these. And don't use them in people with liver impairment. All right. What if someone has bad diarrhea? There are drugs that are opiate agonists, but they don't penetrate the blood-brain barrier. They just work in the bowel. So this drug that you can get over the counter, loperamide, that's this drug, Imodium. By prescription, there's diphenoxin with atropine, that's Modafinil, and diphenoxylate with atropine, that's Lomotil. These can cause drowsiness, lightheadedness, dizziness. They can also cause paralytic ileus, so use these with some caution. They delay the passage of fecal masses. They allow increased absorption of water, so they diminish propulsive peristalsis. Also, there's the bile salt binding resins. Remember, I told you those will cause constipation? Well, you can use them also for diarrhea. We've talked about those drugs before, so I'm not going to talk much about them. Then there's the bismuth compounds. This is Pepto-Bismol. Bismuth subsalicylate. How this stuff actually works is not clear, but it seems to inhibit prostaglandins that increase bowel motility. This stuff is great if you travel and you get some sort of, shall we say, local friend that causes you to get some sort of tourist trots. This stuff will stop your diarrhea. The problem is it's going to turn your stools black and it's going to turn your tongue black. So warn the patient about that because they'll freak out. Also, it's got salicylic acid in it. Use it short term. Finally, what if you have some sort of neuroendocrine tumor that causes carcinoid syndrome and you get this terrible diarrhea because of that? The drug of choice is octreotide. Octreotide. We're going to see octreotide again when we get to the endocrine drugs, which will be pretty soon. Octreotide is also used for esophageal varices. Do you know what those are? Esophageal varices. Blood vessels that protrude into the esophagus and get eroded and bleed. What causes esophageal varices? Congestion on the right side of the heart, so right-sided heart failure, or other sort of liver dysfunction will cause the vessels in the esophagus to enlarge, and they will bulge into the lumen of the esophagus. You can shrink those down using octreotide. Octreotide is available as a subcutaneous injection. This will cause nausea and abdominal pain and gassiness, flatulence. It can increase the risk of gallstones. It can also cause hypothyroidism. It can mess with blood sugar and cause dizziness and headache. All right. Are there any questions over any of the drugs we have talked about tonight? Anything you want more information on? Anything about bowel stuff, treatments? Well, I'm going to let you go a little bit early. Monday, we will talk about contraceptives. So we'll look at oral contraceptives and then we'll get into reproductive drugs. That will lead us into endocrine drugs. And then for the endocrine drugs, we will get into antibiotics and antivirals. Okay, Miss Bailey, have a great night.
You too. Thank you.
Okay, bye now.
Bye.